Postmenopausal osteoporosis, bisphosphonate therapy guided by DEXA and FRX. Postmenopausal osteoporosis affects is almost equal to 30% of women greater than or equal to 65 years and contributes to is almost equal to 2 million fragility fractures annually in the United States. The disease results from estrogen deficiency, driven acceleration of osteoclast activity and impaired osteoblast function, leading to a net loss of bone mineral density, BMD. Dual energy X-ray absorptiometry, DEXA, with a lumbar spine T-score less than or equal to 2.5 or a FRAX 10-year major osteoporotic fracture probability greater than or equal to 20% is the cornerstone of diagnosis. First-line oral bisphosphonates, e.g., alendronate 70 mg weekly, reduce vertebral fracture risk by is almost equal to 43% and hip fracture risk by is almost equal to 30% while requiring routine monitoring of calcium, vitamin D, and renal function. Key points. Note: postmenopausal osteoporosis prevalence is almost equal to 30% in women greater than or equal to 65 years and is almost equal to 50% in women greater than or equal to 80 years, NANS 2022. Who defines osteoporosis as a lumbar spine or femoral neck T-score less than or equal to 2.5, SD equals 1.0. A FRAX 10-year major osteoporotic fracture probability greater than or equal to 20%, or hip fracture probability greater than or equal to 3%, meets treatment threshold per NOF 2023 guidelines. Alendronate 70 mg orally once weekly for greater than or equal to 3 years reduces vertebral fractures by 43%, NNT equals 20, and hip fractures by 30%, NNT equals 22. Ibandronate 150 mg for every 3 months, or 3 mg for monthly, yields a 28% reduction in vertebral fractures, NNT equals 25. Zoledronic acid 5 mg for annually improves lumbar spine BMD by 5.3% and reduces hip fracture risk by 41%, Horizon PFT, 2007. Calcium 1,200 mg per day plus vitamin D 800 to 1,000 IU/day maintains serum 25 OH vitamin D greater than or equal to 30 nanograms per milliliter in greater than or equal to 90% of patients. Oral bisphosphonate-related esophageal ulceration occurs in 0.5% of users. Osteonecrosis of the jaw, ONJ, occurs in 0.01%, oral, and 0.1%, 4. DEXA should be repeated at 2-year intervals. A greater than or equal to 3% BMD increase predicts greater than or equal to 50% fracture risk reduction. Discontinuation rates reach is almost equal to 50% at 12 months. Quarterly or semi-annual dosing improves adherence to is almost equal to 80%. Overview and epidemiology. Postmenopausal osteoporosis, PMO, is defined as a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration, leading to increased fragility. The International Classification of Diseases, 10th revision, ICD-10, code is M81.0, postmenopausal osteoporosis. Globally, greater than 200 million women are estimated to have osteoporosis, with the highest prevalence in North America, is almost equal to 15% of women greater than or equal to 50 years, and Europe, is almost equal to 13%. In the United States, the Centers for Disease Control and Prevention, CDC, reported 10.3 million women with osteoporosis and an additional 44 million with low bone mass in 2021. Age-sex distribution shows a steep rise after the 5th decade. Prevalence is almost equal to 10% at age 55 to 59, is almost equal to 30% at 65 to 69, and is almost equal to 50% at greater than or equal to 80 years. Racial differences are notable. Non-Hispanic white women have a 1.5-fold higher prevalence than black women, 30% versus 20% at age greater than or equal to 65. Pathophysiology. Estrogen deficiency after menopause accelerates osteoclastogenesis via upregulation of receptor activator of nuclear factor kappa B ligand, RANKL, and downregulation of osteoprotegerin, OPG. The RANKL/OPG ratio rises from a baseline of is almost equal to 0.5 to is almost equal to 1.2 within 2 years post-menopause, increasing osteoclast surface by is almost equal to 30%. Concurrently, estrogen loss diminishes the WNT/beta-catenin pathway, reducing osteoblast differentiation by is almost equal to 25% as measured by serum procollagen type 1 and terminal propeptide, P1NP, levels falling from 45G/L to 30G/L. Genetic contributors include polymorphisms in the COL1A1, SP1 gene. Risk allele frequency is almost equal to 30% in Caucasians, conferring a 1.4-fold increased fracture risk, and the VDR-BSMI variant, risk allele is almost equal to 25%, associated with a 1.2-fold risk. Clinical presentation. The classic presentation of PMO is an asymptomatic decline in BMD detected incidentally on DEXA, but the disease often manifests after a fragility fracture. Vertebral compression fractures account for is almost equal to 30% of osteoporotic fractures, with 70% of patients reporting acute back pain, height loss greater than or equal to 2 cm, and kyphosis. Hip fractures represent is almost equal to 15% of fragility fractures, 90% of hip fracture patients are women, and 30-day mortality reaches is almost equal to 20%. Wrist, distal radius, fractures comprise is almost equal to 20% of cases, typically presenting with forearm pain and limited range of motion. Atypical presentations are common in the elderly, greater than 80 years, and in patients with type 2 diabetes mellitus, T2DM. In T2DM, BMD may be normal or even elevated, mean lumbar spine T-score is almost equal to 0.8, yet fracture risk is 1.7-fold higher due to compromised bone quality. In immunocompromised patients, e.g., long-term corticosteroid users, vertebral fractures may occur without preceding pain, detected only by imaging. Diagnosis. 1. Clinical risk assessment, obtain age, sex, BMI, prior fragility fracture, parental hip fracture, glucocorticoid exposure, rheumatoid arthritis, secondary osteoporosis, smoking, alcohol, 3 drinks/day, and vitamin D status. 2. Laboratory panel. 3. Imaging, key points, serum calcium, total, 8.5 to 10.2 mg/dl, sensitivity is almost equal to 85% for hyperparathyroidism. Albumin-adjusted calcium if hypoalbuminemia. Serum 25OH vitamin D 30 to 100 nanograms per milliliter, deficiency less than 20 nanograms per milliliter. Phosphate 2.5 to 4.5 mg/dl. References. 1. Patel et al. A narrative review of the pharmaceutical management of osteoporosis. Annals of Joint. 2023, 8:25. PMID 385292240, https://pubmed.ncbi.nlm.nih.gov/385292240. DOI 10.21037/AOJ 23-2. 2. Singh et al. Whole body vibration therapy as a modality for treatment of senile and postmenopausal osteoporosis, a review article. Curious. 2023, 15, 1E33690. PMID 367933830, https://pubmed.ncbi.nlm.nih.gov/367933830. DOI 10.7759/curious.33690. 3. Udine MZ et al. Comparing teriparatide and bisphosphonates for postmenopausal osteoporosis, a systematic review and meta-analysis of RCTs, Health Science Reports. 2026, 9, 3E72096. PMID 420222682, https://pubmed.ncbi.nlm.nih.gov/420222682. DOI 10.1002/HSR 2.72096. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.